So I'm Peter Allen, and I'm a perfusionist at the London Health Sciences Centre in London, Ontario, Canada. That's an hour flight from Eric in Montreal, 30-minute flight to Toronto, 30-minute flight to Detroit, and a 30-minute flight to the Cleveland Clinic. So where I think we're getting hammered with snow at the moment, and I'm leaving early. So anyways, so I just wanted to chat with you about the clinical applications of the Quest at our site, and some of the things, the usual things that you'd be thinking about, and maybe some not so usual things, some applications for it. So as Eric very eloquently went into this, the goals of myocardial protection is not only to facilitate the operation, but also to avoid the iatrogenic injury during cardiac bypass. We want to evade reperfusion injury by altering the conditions and the delivery and the composition of the solutions that are distributed. Although the myocyte is a primary casualty of ischemic surgical ischemia, the coronary endothelium is also vulnerable to injury, and the endothelium is extremely active and important tissue in releasing vasoactive factors that regulate organ blood flow and systemic blood pressure. Although, there we go. The endothelium is the intermediate phase between the blood and the myocardium, and an edema of the endothelium can result in deleterious release of activators, platelet activating factor, endothelin-1, superoxide anide, histamine. It can reduce the reduction of nitric oxide, adenosine, and prostacyclin. So our site it's a teaching site, and we have a little bit of a history there. In London, we had two centers doing cardiac surgery. Those two centers came together. So as you can imagine, as a number of people in the audience have indicated, we have a number of different methods by which we had to deliver the cardioplegia. So some of the things we got some old school guys who would give a liter dose of crystalloid cardioplegia for induction. They like that because they get a rapid arrest. And then they would follow that up with a variable ratio maintenance doses. We had two different types of variable ratio solutions. We were using the two-pump method, one pump delivering blood and the other using crystalloid. We used only the one bag of the high K, as been described earlier, and then we just reduced the ratio to provide the low potassium. We had some surgeons who were giving cold intermittent doses. We had some people giving tepid intermittent doses. We had one that likes to give continuous normothermic cardioplegia. We had some that like to give hot shots, and some like to give reperfusase with mannitol and lidocaine. And as we're reviewing our things, we were seeing some of the things that have been reported. Certainly we were having problems with hyperglycemia. We know that maintaining euglycemia is very important. Hemodilution factors, of course, very important. And so this got us to thinking perhaps a change from the variable ratio systems of the Quest might be a platform that could help meet the demands and provide some flexibility, perhaps for future considerations, and potentially to meet some of the best perfusion practice recommendations. So microplegia is just simply the elimination of crystalloid used to carry the arresting agents and cardioprotective drugs, and only blood diverted from the extracorporeal circuit is used, and we just add the cardioprotective and arrest agents to that to achieve the diastolic arrest and preserve the myocardium. And as has been outlined before, we know that the Quest uses piston pumps to draw the blood from the arterial line, and it kind of goes on uses the theory that enhanced myocardial protection is offered by limiting the dilutional load to only the drugs delivered, and that oxygen delivery is enhanced by the result of the higher hematocrit that the myocardium sees. Piston pumps also deliver concentrated amounts of myocardial protecting arrest agents to achieve the anaerobic diastolic arrest. In addition to microplegia, there's a wide range of variable ratios that can be employed from whether that's pure crystalloid to ratios from 1:1 to 66:1. But what's an important feature, I think, to this is that there's independent control of your potassium and cardioprotective drugs. So when if you're using a variable ratio system, yes, you're reducing the amount of potassium, but you're also reducing your variable rate. You're also reducing the amount of cardioprotective drugs. So there's independent control of those two elements, and so you can give low potassium, but you can maintain the same level of your cardioprotective agents. So when we made the change to the Quest, we did have some learning curves. What we first saw that hyperglycemia was no longer an issue because it eliminated a lot of the glucose load that we'd seen. But what we did see that hyperkalemia was becoming one, and as Eric mentioned, he has cases where they have potassiums at 7 and you're still having breakthrough beating. And where we saw that coming to fruition was actually in the surgeon that uses the normal continuous cardioplegic arrest. And so we tried some variable ratio maneuvers, and what I'm referring to there is sometimes as the potassium's going up, maybe you can tweak down with the variable ratio pump, you could tweak down how much of the crystalloids you're given there by decreasing the amount of potassium. But what we were seeing was the heart would start to beat, and so now we had potassiums that were going through the roof. So we contacted 10 different institutions that were using continuous warm cardioplegia, and we made some minor changes. And what we found was that it was all about the additive solutions. And so this is what we're currently using. So we started out with what we added was the lidocaine, and that the lidocaine and the insulin made a big difference. And so once we introduced that, we didn't have the potassium problems we were having. And if we did have any breakthrough beating with the continuous cardioplegia surgeon, we could simply give a purge of potassium. So there's a purge function. If you touch the arrest agent button, you can you touch the arrest agent button, then you can give a purge of potassium, and we found that would arrest the rest of the heart again. You can also give a bolus of the additive solution. So same thing, press the arrest button and the additive button, and you can give a purge of arrest protective agent, and that sometimes works too. So we know that when we change a technology, it's incumbent upon us to make sure that what we're doing isn't the McCormick factor, that we're seeing things that we want to see, and that there's a responsibility on the individuals to take a look and see that have the changes we've made, is there proper evaluation to be sure that there's evidence-based practice there and that your changes are worthy. So we looked at we took a look at it twice. The first look at it was immediately after we started using the Quest, and we did a retrospective analysis of 230 patients undergoing elective and urgent cardiac surgery. We looked at aortic procedures in patients with preoperative hemoglobins of 100 or less were excluded. We looked at demographics, perfusion data rates, the use of the intra-aortic balloon pump, and ultrafiltration. And we looked at 6 weeks prior to the introduction of the Quest and 6 weeks after the institution of the Quest, allowing for a 2-week learning curve for the operators. And the demographics of the patients were approximately the same. There were some differences in the outcomes. And what we saw was, in addition to the fact that we had greater control of our glucose, this is clearly evident to us because we weren't having to give insulin drips to the patients anymore. We did find there was a trend for less transfusion requirements in the operating room. There was a significant decrease in the use of the hemoconcentrator. The early findings showed us that there was a 36% decrease in the use of the intra-aortic balloon pump. And while that may or may not be important to some people, what we looked at was some of the transfusion rates, and we showed that 97% of the patients who received an intra-aortic balloon pump also received a blood product. And 53% of those patients on our institution received more than 4. And I think what happens there is, as things are going downhill, you start optimizing the patient, and so that in itself becomes a transfusion sparer. Here's some examples of some of the procedures we've done with 4 units up to high doses up to 43. liters, and the potassium ranges, relatively within control. Glucoses were within control. I actually recently did a case, 4-hour case from hell, 90 liters of cardioplegia given, and again, ranges were within normal. 90, 4 hours cross-clamp.
Well, explain to him the crystalloid.
The crystalloid component was probably like 600, of that 90 liters. Yeah. 90 liters of blood of microplegia. Yeah. So we did this prompted us to take a longer look at what we were doing. And so we looked at patients, 1,128 patients who underwent surgery between June 2006 and January 2008. The patients were divided into 2 time cohorts, and we looked at statistical analysis that was performed, essentially retrospective, but it was retrospective analysis of data that was prospectively entered. And so we did an analysis on the groups to be sure that they were similar. So the results of that showed that the patient demographics were similar between the 2 groups. The predicted risk of death and any of one of the 10 major complications were not statistically different. However, we did show some statistically different outcomes with those 2 groups. The GI bleed rate was significantly different. Renal failure requiring dialysis, significantly different. One of the 11 major complications, statistically different, and the length of stay in the ICU and the hospital, both lower. Some of the points of interest between the 2 groups: with the variable ratio group, the total cardioplegia that they were receiving was 4,618 compared to the 5,251 in the MPS group. The crystalloid component, the variable ratio, 688 mils compared to 61 mils, which is just strictly the drugs. And the hemoconcentrator use, 43% in the variable ratio group compared to 23% in the MPS group. The intra-aortic balloon pump use continues to be reduced. So pre-MPS group, when we're doing approximately 1,500 cases a year, 108 balloon pumps. And with the introduction of the MPS, we saw a rapid drop in the use, and that usage is still remaining down to 54. So the MPS is a flexible platform, and so I want to look at a few of maybe some of the expected things and some of the unexpected things. Certainly, with minimally invasive surgery, Eric went over custodial and del nido very eloquently, and certainly if you're using a couple of different cardioplegia solutions on the shelf, you can certainly use custodial under the traditional method. You can use the traditional del nido method, or you can use the micro del nido method, which is described by the Callan-Berry-Cooper protocol, and this is a group out of Marietta, Georgia. And what they do is they'll have the Quest blood crystalloid setting on total blood. In the arrest pouch, they've got that set at 21 mil equivalents per liter. In the additive pouch, it's 32 mils of mannitol, 20% mannitol, 13 mils of 2% lidocaine, 8 mils of magnesium sulfate, which gives them a total volume of 53. They'll load the pouch with 40 mils of this solution, and they'll give it as a cold arresting dose between 8 to 15 degrees. And then if they're giving a warm reanimation dose, they'll give that at 33 to 36 degrees Celsius. They do the induction dose based at 15 mils per kilogram for the cold antigrade, and they use the ideal body weight for that for the obese patients. And I've got a chart that's coming further down if people want snapshots of that one. So they'll use a minimum dose of 1 liter and a maximum dose of 1,500. Subsequent doses will be 200 to 300 mils of cold, and I'll show you their dosing assessment on that. They'll use half-dose settings for the arrest and for the arrest and the protective agent. And if the potassium is higher than 5.5, they'll turn the potassium down to 0. And the warm reanimation dose is 400 mils with the potassium setting at 0. and the additive solution at 21. So what they'll do is they'll target a root pressure of 200 to 250 millimeters of mercury. That's reflected back on the MPS at 250 to 300, and we have to take into consideration that the pump's lower and that there's a pressure head difference between the aortic root and where we are with the pump. So that's reflected at about 250 to 300 on the MPS. So their initial induction dose they'll give, and is they'll look at inadequate arrest or premature activity. They'll want to take a look and reevaluate the delivery system. Is the clamp good? Is the AI, that sort of a thing. And from there, if there's a problem, then they'll reassess and then make decisions from there. And I guess one of the things, if you had to change solutions, you could do that on the fly too, I guess. But assuming things are going well, they will go 60 minutes, and after 60 minutes they will reassess. If there's sustained activity, they'll evaluate, and they'll sort of look at where are they in the case. If the case is going to be done soon, then they'll forget the subsequent dose, or it's a physician decision on whether they'll give another dose or not. And then, of course, they'll give the reanimation dose of 400 milliequivalents with no potassium. Here's their obese protocol, so a chart for their ideal body weights here. So, flexibility MPS, maybe the not expected uses of the MPS as a platform, and maybe some future applications that could potentially affect us down the road. So we have a big neuro center at where we are, and maybe one of our claims to fame is when Della Reese collapsed on Johnny Carson's stage, she was sent to the London Health Sciences Center for her aneurysm clipping. We do a number of cerebral aneurysms, but we don't have a big run on the use of extracorporeal circulation with them. But in the years I've been there, I've seen us use deep hypothermia, less circulatory arrest, and we've also tried some regional cooling. And two important things on this slide. So the first one shows one of my mentors, Jim McDonald. He's a pioneer in perfusion in Canada, and I promised Jim that at some point in every presentation I would give, I would use the word extracorporeal circulation in there. So here we have Jim McDonald with an extracorporeal bliss running this the quest for this cerebral aneurysm. And what they did was they cannulated the femoral artery. They did a cut down. They did expose the femoral artery as an inflow cannula. Just used the patient's pressure to feed the quest, and they cannulated the internal carotid artery and cooled the brain down to about 30 degrees for that particular surgery. And here's this is the aneurysm, so a nice big area here, and that's eliminated. And so that case went on successfully. The patient was awake the next day and up to the floor. Neuroprotection, so this is kind of good. I'm following our neuro guy. So there's some potential for neuroprotection regional cooling for the treatment of stroke, and we've been looking at this. And with this, we incorporate the Quest as the Quest and a centrifugal pump, and you'll see reasons why we have to do that down the road. But this particular cannula is called the DuoFlow cannula. It's made by the Neuroprotection company, and they'll insert this cannula femorally up into the carotid artery and perfuse the hemisphere, and we can regionally cool that portion of the brain to do that. So what we did, we used a stroke model using swine. We didn't have to use monkeys. So and what we did was, in a frontal orbital craniotomy was performed. The middle cerebral artery was temporarily clipped for 3 hours to induce ischemia. This was followed by a reperfusion, so they took the clamp off and reperfused the brain for 3 hours. And so we had half the animals were normothermia was maintained. The other half of the group, using this thermopeutics catheter that was inserted, we cooled the side of the brain down to 26 degrees. And keep your fingers crossed this thing works. Well, it's looking promising. Anyways, this is just their circuit, and because of the small diameter, we couldn't really get a big enough pressure head to feed the Quest. So we used the centrifugal pump as a bit of a primer pump for it. This allows us down the road that you could use some of the safety features of the Quest, and we'll talk about that in some future slides here. It's a bit jittery, isn't it? So, yeah. Anyway, there's the pig. So the animals were humanely terminated with euthanol. The brains were fixated and removed for evaluation of stroke volume using MRI and histology. And with MRI, the stroke volume was significantly smaller in the hypothermia group, and the pathology stroke volumes were larger in the controls than those that were treated with hypothermia. So in my city, we've got a thing called a code STEMI. And what we sort of look as time as myocardium. So in the field, paramedics can follow specific guidelines and can activate the code STEMI. And what it does is that activation activates the cath lab staff, and the patients bypass the emergency department and go directly to the cath lab. And so there's the potential that this type of technology could be used for a code stroke. So time is gray matter. A similar system could be used to activate and initiate regional cooling. And perhaps, we've heard today some great talks on some of the artificial blood products. You could use, potentially you could use the additive pouches to give maybe some neuroprotective agents, maybe mannitol, or maybe they could give amoxicillin to improve oxygen delivery to the thing. So future directions for sure with that. But clinical lab to the clinic. We, in fact, took a patient, a 49-year-old, presented with a giant aneurysm, partially thrombosed to the right middle cerebral artery. Opening the aneurysm for evacuation of the thrombus was required to allow clipping. This would require a lengthy period of complete ischemia and a high risk of stroke under these normothermic conditions. And their feeling was hypothermia was the most effective protectant against cerebral ischemia. However, total body cooling techniques using extracorporeal circulation could be associated with some significant risks, and so they elected to do this patient using the selective brain cooling. We thought that perhaps that would offer similar neuroprotection as we would with the cardiopulmonary bypass, and so we used the Thermopeutics cannula to do that. So reperfusion of the blood in the right common carotid resulted in rapid hemicranial cooling to 26 degrees Celsius. This permitted a prolonged period of middle cerebral artery circulatory arrest and aneurysm clipping, and the clinical outcome was excellent. The patient was up to the floor the next day. And these are just some pictures of the aneurysm here and the ligated and clipped aneurysm. One of the things about that is that there's usually 2 or 3 arteries that are feeding this aneurysm, and so this is where some of the safety factors of the autoregulation come into place. So we could dial the flow that we wanted when all the arteries were open, and as they started clipping off the feeders, the autoregulation of the MPS can reduce the flow to that, thereby avoiding any hypertension issues with the delicate tissue that they're working with. So I like some of the safety features of that. So it can be used if you're delivering a retrograde. You can dial it up to retrieve your coronary sinus pressure, hit the autoregulate. It'll maintain that pressure for you. If you're using multiple vein grafts, as the surgeon's clipping each one down independently, you got the auto mode on. It'll automatically ramp down the flow rates. Clipping of the aneurysm, and I've used it in thoracoabdominal situations where we've been use the Quest to perfuse renals and SMAs and things like that, and hitting the autoregulator as they were excluding those vessels came in handy for that. These are just other pictures in case the movies didn't work. So, but it just shows that the cannula is sort of as a double cannula system that one fits inside the other, and it's a manual inflate on the manual inflate balloon on the tip of the cannula. This is a word from our this is Dr. Bob Kei. He's our champion. Hopefully he'll fire up here. Yep. Yeah, well, we'll skip Bob. We'll just skip that. Yeah. Go right to the next slide. So basically, in conclusion, we found that the change to the MPS has provided us the ability to address a number of the areas of concern for our patients that reach beyond myocardial protection. Many of the things we find were consistent with best practice, and it's a platform for which we can apply future considerations. Special thanks to the team back home, and hope you're enjoying your stay here in Winter Park.